this. So welcome everybody to the Dementia Knowledge Network for October. I would just like to acknowledge that our meeting is being held on the lands of the Wurundjeri people of the Kulin Nation, and I wish to acknowledge them as traditional owners of the land on which we meet. I would also like to pay my respects to their elders past, present and emerging, and I will throw to Sarah to introduce our lovely guest presenter who's jumped in for today. Thank you.
Thanks, Elizabeth, and thanks, Michelle, for coming along at the last minute. Can I introduce to you Michele, is it Callisaya? Is that how I say it?
Perfect, yeah.
Oh, excellent. From the Medical Research Future Fund. And Michelle's going to talk to us about the right to rehabilitation for people living with dementia. Thanks so much, Michele.
Thank you. And yes, look, I have just popped these slides together last night, so hopefully they'll be okay. So I thought what I would do is tell you a little bit about how we got this grant, so the kind of work that kind of led up to it, and then tell you a little bit about the actual grant, because we obviously have only just got it and it's only just started, so we can't give you any results just yet. So I'll share my slides. Now, can you see the full slides now?
Yeah.
Great. Okay, so I am from the National Centre for Healthy Ageing, which is a partnership between Monash University and Peninsula Health. I'm not sure if you've heard of it or not, but it's funded by the Commonwealth Government, and it's been up and running now, I think it's in its third year. So it's a lovely partnership between a university and a health service. This is the fantastic grant that Kate and I are on, and it's something that obviously Kate has felt very passionate about and really advocated for a long time. So fantastic for you, Kate, to be on this grant, and it has lots and lots of partners, as you can see there. So we've got obviously Monash University, the University of Tasmania, Uni of New South Wales. I haven't actually put Uni of Wollongong there, Kate. I'm not sure whether you want me to keep putting the Uni of Wollongong on.
You probably should, yeah.
Thanks, yep. OT Australia, Physiotherapy Australia, Australian Psychological Society, particularly their Ageing Interest Group, Dementia Alliance International, Dementia Australia, and then the two primary health networks there. So the title it really says it all. It's the right to rehabilitation for people with dementia. We really want to try and improve access to rehabilitation type treatments developed by Allied Health for people with dementia living in the community. This is the list of the long list of all the investigators on the grant, as well as the names of the representatives for each of our partners. So I thought I'd just start by telling you a little bit about me, how I ended up in this field of dementia rehabilitation. So my background's a physiotherapist. I've worked actually in Hobart for most of my career. I worked at the Royal Hobart Hospital, mainly in the area of rehabilitation, particularly neurological rehabilitation. Worked with people with multiple sclerosis, stroke rehabilitation, but everything from traumatic brain injury to people who have had an amputation. And I also worked at the University of Tasmania. Just before COVID, I moved to Frankston to Monash and Peninsula Health, and then of course COVID came along, and it was yeah, very difficult to kind of get to know everybody. I have a number of interests that really cover both my clinical career and also my research interests. So I've been really interested in the role of both gait and cognitive function on falls for older people. I've sat on the Australian New Zealand Falls Prevention Society executive, as well as the Physio Research Foundation Grants Committee, and I've just stepped off the Dementia Australia Research Foundation Grants Committee as well. So that allowed me to have a really nice overview of all the different grants that were coming in around Australia from all the up and coming researchers. Just a really great way to kind of stay abreast of the field. As I mentioned, a lot of my work as a physiotherapist has been in rehabilitation, particularly stroke rehabilitation. And so I think that's really kind of given me that nice background for this project. Although I didn't see a lot of people specifically for post-diagnostic rehabilitation for dementia, it gave me that kind of theoretical background on what is involved in rehabilitation, and I'll go through that a little bit in this talk. So I guess with my research interests, I did my PhD way back, started in 2005, finished in 2010. And then was lucky enough to get a national early career fellowship that was to look at the role of cognition and brain structure on gait and falls in older people. So some of the work that we did looked at how balance and gait increases the risk of falls, and then the different cognitive domains that are important to look at when considering someone's falls risk. And what we found was that it was the domains of particularly executive function and processing speed that were associated with falls. But if someone had a combination of poor balance and any of the 4 cognitive domains, so executive function, processing speed, memory, or visuospatial ability, they were at a higher risk of falls, which makes sense. And then this work actually led to the development of an app that older people use at home. So up on the top right-hand corner here, you can see Professor Kim Delbert. She developed this fantastic app called Standing Tall, which has over 2,000 different balance exercises in it, and she's done a large randomised control trial looking at its effect on reducing falls. But what we did together was actually adding to these balance exercises some cognitive exercises as well. And so not only did that make the balance exercises more interesting, but it also challenged cognition as well. And what I thought I'd do is I'd just give you a little bit of a demonstration. You don't have to, but if you would like to, you could stand up. And what we get people to do in this is find, basically, we give them a level of balance challenge that is appropriate to them, and that's assessed within the app. And as they go along, they rate how challenging it is, and if they say that it's easy, it gets harder, and if they say it's too hard, it gets easier. So if you wanted to stand up, you could stand with your feet together. Obviously have a chair there just to hang on to if you need it. If you feel like your balance is really, really good, you could stand on one leg if you would like to. And so what I'm going to do is I'm going to play this, and what I want you to do, if you think your cognition's not too bad, I want you to count the number of hearts that you see. This is called selective attention. If you think your cognition is absolutely wonderful, I'm going to give you a triple task. You're going to count the number of hearts, but you're also going to count the number of symbols that you actually see. All right, here we go. Get ready. Super. Okay, you can sit down. So you should have seen 10 images. Does anyone want to volunteer how many hearts they actually saw? 2. Yeah, excellent. Excellent. Yep.
But that was remarkably difficult.
Well, especially if you get to do a triple task. We ran a study using this app with people who had subjective cognitive complaints and mild cognitive impairment down in Hobart. They did it in their home for 6 months. And unfortunately, in the middle of the trial, COVID came along, and so we couldn't fully analyse the results of the study. But what people did say is that when they couldn't go to their normal classes, this was fantastic. They could do it every day at home and keep fit. We've got another study happening up in Sydney, and that's 500 people, and that's almost finished. So it'll be interesting to see the results of that one. Right, now I can't find my board. Okay. So some of the other research that we've looked at is just the role of cognitive function on walking. And we often think of walking as a very automatic kind of activity, but in fact, if you think about it, you can see on the left, you know, to get through this environment of different cracks and different, I guess, I don't know, I think this is a little bit of a roadwork type situation. You need to have good planning, good judgment about your own ability to get through there, and good visuospatial skills. The one in the middle, I think we've all seen people not being able to divide their attention. So they're looking at their phone and either twist their ankle in a pothole or run into a pole. I've almost done that embarrassingly. And then the third picture, I think, is a really interesting one. So if you look at the lady who's crossing the road, really walking for her is almost a dual task in itself. And if you've ever been to the Samburu crossing, I think it's called, in Japan, you'll know that not only are there hundreds of people crossing the road, there are lights flashing everywhere, the music blares, and so it's a very distracting environment. And so you can imagine how much attention this lady had to be taking to cross the road. If she got nudged or knocked, she'd have to have really good processing speed not to fall over as well. And so really interestingly, what we found is when we had people just walking in a very standard environment, that these specific cognitive functions of executive function, processing speed, attention and visuospatial ability were all related to slower walking speed and the way that people walk. So we actually kind of said, okay, well, actually, in older people, is walking a good measure of someone's cognitive function as well? Or perhaps is walking a window into the brain? And so we were able to look at a whole range of MRI scans and see how these MRI scans related to people's walking. And so what we found is that the more vascular disease there was on the MRI scans, as you can kind of see on the left-hand side here, this was related to slower walking speed. But the other really interesting thing was that in terms of grey matter atrophy, it wasn't just in the motor or sensory parts of the brain that were related to slower walking speed. It was also atrophy, particularly in the frontal areas of the brain, which is important for executive function and planning that were associated with slower walking speed. So that was almost like my early career type research. And so what happened in, I think it was around 2016, 2017, the Australian government offered a whole range of fellowships for researchers to, particularly those that were slightly outside the field of dementia, to come into the dementia field and really boost research in the dementia field. And so I was lucky enough to get one of those fellowships, and it really, I think, took me from looking at that stage just of generally of older people and cognitive function into the field of dementia research. And so my fellowship was around improving the physical and cognitive health of older Australians, and it really got me interested in what was the role of physiotherapy and dementia. So obviously we know that mobility is really important for people just to carry on doing their activities of daily living, to maintain leisure activities, but also if mobility is poor, it increases the risk of all sorts of things like falls, hospitalisation and early admission into nursing homes. Interestingly, if you didn't know, you need a speed of around 0.4 metres per second to be able to comfortably walk around in someone's home effectively, and to cross the road before the red traffic lights, the red pedestrian signal changes, you need to be able to walk at speeds of around 1.2 metres per second. If it's a hospital or a nursing home, they allow for a slightly slower walking speed of around 1 metre per second. And so the way that we measure that is, as physios, is we get like a measured distance of say 10 metres, we get a stopwatch out, and if someone takes 10 seconds to walk 10 metres, then that's 1 metre per second. So it's pretty easy to work that out. And gait speeds of less than around 1 metre per second put people at a higher risk of falls and hospitalisation. So what about, you know, what kind of speeds are average for people with dementia compared to mild cognitive impairment to people that don't have dementia? And so we were able to look at this in a cognitive clinic sample of over 600 people. And so if you look at the x-axis up here, you can see the walking speed. So I'm not sure if you can see my pointer, but I'm trying to point to 1 metre per second there, and then there's 1.2 metres per second, which is that speed that you need to be able to comfortably walk in the community. So what you can see here is this is people without a cognitive diagnosis. This is people with mild cognitive impairment. Then you've got mild, and then you've got moderate dementia. So on average, the people with dementia walked slower than that 1 metre per second that puts people at risk of fall, and also much slower than that 1.2 metres per second for people to be able to walk in the community. The second kind of lines of graphs there are the fast walking speeds. So we ask people to walk as fast as they possibly can, and even when asked to walk as fast as possible, the people with dementia are only just getting up to that 1.2 metres per second. So I think that's really important to think about people's ability to participate in activities of daily living and falls risk, but you know, being able to walk at a reasonable speed is really important. Another study that we recently published and was led by our statistician Taya Collier, who's up there, is we looked at around 16,000 people from the ESPRI study. I'm not sure if many of you have heard of the ESPRI study, but it was a randomised control trial of aspirin looking at a range of health outcomes in 16,000 older people in Australia and the US. But what we did is that we looked at people who were very healthy at the start of the study. They didn't have many chronic conditions, followed them up over time. And what was really interesting is that those that had the greatest decline in gait speed were more likely to develop dementia. Obviously, those that had a decline in cognition were more likely to develop dementia, but it was those that had a decline in both gait and cognition over time that had the highest risk of dementia. That's interesting in itself, but I think what's really interesting is that we see that mobility is actually starting to decline a long time before someone gets a diagnosis. And so I think that, you know, by the time someone does get a diagnosis, then their mobility is already impacted. And so, but the good thing is that there are things that we can do about it. So as I mentioned, I was really interested in, well, hey, what do physiotherapists do in the dementia field, and how well we did it? How well do we do it? So I started looking up in the literature, you know, what kind of evidence is out there. The kind of things that I was seeing was, well, we exclude people with dementia in our study, so this wasn't very helpful. Or in clinical practice, I was hearing, particularly as I was working with people with stroke, gosh, they've got dementia, they have no rehab potential. And this was really, I guess, a really big concern to me, because often it was actually the people who had that diagnosis of dementia and wanted to get home that we actually needed to put in more treatment to get them home. And so that became a really big focus of the kind of work that I have done since. I recently looked at the National Stroke Audit that has nearly every, it has an audit every year of stroke patients from around Australia, and I looked at the quality of care that people received, comparing those with dementia and those without dementia, and those with dementia received poorer quality of care in hospital than those that didn't have dementia. And that was things like not seeing a physiotherapist and an occupational therapist in the same amount of time that someone without dementia would see. We carried out a systematic review looking at physiotherapists' knowledge, confidence, attitudes and beliefs about providing care for people with dementia, and this was led by one of my PhD students, Stephen Quick. What we found, and it says physical therapist there rather than physiotherapist because it was published in America, is that physiotherapists did lack knowledge and confidence in working with people with dementia. There was some attitudes around and some stigma around their ability to engage and improve. And so I think really there's an enormous amount to be done in this space, both in the undergraduate education of allied health professionals as well as postgraduate. And that is some of the work that Stephen is now doing, particularly looking at undergraduate, what is taught and how prepared undergraduate physiotherapists are, but also some work with experienced physiotherapists and really looking at what is excellence in care and what we should be knowing and learning as physiotherapists. I was also involved a few years ago in writing a chapter for this book called Dementia Rehabilitation, and you may know about it. Kate wrote one of the opening chapters of this book. It was edited by two Australian dementia researchers, Lee Fei Low and Kate Laver. And my chapter was looking at the role of exercise on physical function in people with dementia. And I think the really important thing is that there is really good evidence that exercise can improve a range of different physical measures in people living with dementia. And that ranges from balance, strength, mobility, endurance to improving activities of daily living. The evidence for reducing falls for people in the community and residential care is less strong. However, just recently there have been two trials, one in the community that's shown that particularly those with better physical function, we can reduce falls with an OT and physio program, and another study in residential care that showed that a range of balance and strength exercises can also reduce falls in residential aged care for people with dementia. So that's really important. So this book, I suppose, really opened my eyes to the range of things that allied health in particular can do to support people with living with dementia to maintain or even improve both their physical function, cognitive function, activities and participation. There, of course, I'm sure most of you would know there's now a worldwide push for access to rehabilitation for people with dementia after diagnosis. And I think maybe Kate, you've probably scrabbled with this a little bit as well, but that term rehabilitation, I think is a tricky one because a lot of medical professionals think of rehabilitation as, you know, just after a subacute or after an acute event like a hip fracture or a stroke. But the World Health Organization has really said, no, rehabilitation is not just after an acute event, it's for, you know, a holistic approach to chronic disease management, not just after an acute event. So that is the word that we adopted in the grant rather than other words that are commonly used like reablement or enablement. Also, rehabilitation now appears as a core recommendation in the World Health Organization Global Action Plan on Dementia. And there is now, I'm not sure if it's actually been released, Kate, the World Health Organization package of interventions for rehabilitation for people with dementia, but we were both involved in that one as well.
I'm not sure it's released yet, Michelle, but soon. Yeah.
Very soon, yeah. Okay, so the definition of rehabilitation that WHO uses is a set of interventions designed to optimise functioning and reduce disability in individuals with health conditions in interaction with their environment. And, you know, I think if you've, again, listened to Kate, you know, it's really seeing dementia as a disability and, you know, that right to access rehabilitation. I'm not sure if any of you have seen this, the International Classification of Functioning, Disability and Health. The World Health Organization used this. I was taught this at a very early stage in terms of my rehabilitation education. And so it's really looking at how a health condition affects a person's body functions, such as strength, balance, mood, cognition, communication, particularly how it affects their activities of daily living, their functional tasks, and participation with life activities or roles, and how that interacts with the environment and personal factors. And that's very much how allied health go about assessing someone and devising a rehabilitation plan in conjunction, obviously, with the person and their family. So what about in the Australian context? So internationally, the World Health Organization says that we should be providing rehabilitation for people with dementia. The recent Royal Commission into Aged Care recommends rehabilitation be a central focus to maintain people's physical and cognitive capabilities, support their self-determination, and facilitate people to remain at home as long as possible, including people with dementia. The quality standards for aged care say the same thing, and the recent memory and cognition clinical practice guidelines really emphasise that people should be referred to allied health to maintain improved function for as long as possible, and that exercise should be strongly encouraged. Dementia Australia has recently released this policy position statement around access to allied health, really just reiterating that there is really good evidence now that allied health services can slow progression of cognitive and functional decline, improve quality of life, and it promotes transition to residential aged care, and it should be offered post-diagnosis. I've probably gone on enough to convince you, and I'm sure you're not the people I need to convince. But you know, I think this is a really multidisciplinary approach. You know, I've obviously my background is physiotherapy, so that's the area that I know the best. But you know, occupational therapy has an absolutely major role, and probably the most well-known role. Speech therapy, particularly for people who have communication problems. I think the other one that's probably not thought about enough, and particularly post-diagnosis, is the role of psychologists and counsellors. You know, I think sometimes as health professionals we forget that getting a diagnosis, you know, is a really hard event to come to terms with, and counselling, psychology, but support groups and other things are so important in helping people get through that especially that first you know, 6 to 12 months. So everybody says that we should be doing it. There's evidence out there, but it really is underutilised despite you know, all the benefits that allied health can have in this area. And it's not that people with dementia don't want rehabilitation. So this was just a quote that I got from a New South Wales report. So of a person living with dementia. So since my diagnosis, I found it very important to seek out appropriate support and put it in place earlier rather than later. I've seen firsthand what a difference it can make to keep active and be physically, cognitively and socially engaged, as it maximises my quality of life. And if you look up Kate, I don't know why I keep, I'm sure you all know how wonderful Kate is, but you know, Kate has really advocated for this. And if you look up some of her work on Dementia Alliance International, you know, it's obviously that Dementia Alliance has done a lot of work to really advocate for rehabilitation for people with dementia. So why isn't it offered? Well, I think the stigma, as I've talked about already, and also a lack of knowledge, you know, assumption that rehabilitation have limited utility, but health professionals also may be apprehensive about giving false hope. So there really is that lack of knowledge and confidence about the evidence for rehabilitation and delivering it by health professionals. Don't know why that's like that, sorry. Oh, and so yes, we've actually looked at this, as I mentioned, in the meta-analysis, and then this was another paper that we did just looking at allied health professionals' knowledge of dementia. And I think there was, you know, there's a lot of room for improvement for all health professionals. This was some work by led by Kate Laver, interviewing people with dementia and their care partners. And so I think it just, some of these quotes, if you just take a little bit of time to read them, just show that there's a number of issues about, you know, not knowing what to ask for, not knowing what's out there, and really getting very little information after a diagnosis. Other problems, of course, are there is no clear model or pathway for brath-riding rehabilitation at the moment, and that is a huge problem. I think the other problem at the moment is, particularly after COVID, long waiting lists. If they weren't there before, there are long waiting lists now. And so even if referrers and providers you know the evidence, they're confident in prescribing and delivering it, I think we've really got a problem of, you know, if people can't afford to pay for this privately, or they have to wait for aged care packages or the NDIS. There are obviously GP chronic disease plans, but you know, they're not enough to fund health professionals often to come to people's homes. So I think, you know, despite there's a lot of talk in guidelines and the Royal Commission, there still is a lot of work to be done in this area. And so I guess that's really led to this grant to try and change that. So we've got a big job ahead of us. The first, well, I guess the overall aim is to improve access to evidence-based rehabilitation treatments for people with dementia living in the community. So year one is going to be looking at co-designing solutions of how we're going to do this, and I'll talk a little bit about that in the next slide, and that'll be with a whole range of stakeholders, including people living with dementia and their care partners, as well as organisations like Dementia Australia. We'll have GPs, allied health professionals, and a number of the different allied health professional organisations. And then in year 2 and 3, we'll test out those solutions. So the kind of questions that we want to try and work on in this first year in the co-design workshops is, how do we empower people with dementia and their care partners to access rehabilitation? So I'll be really interested, once I finish after another slide or two, on your thoughts on these questions. How do we increase referrer and provider, so that's people who work in academic clinics, GPs in particular, as well as allied health professionals? How do we improve their knowledge and reduce stigma? And then how do we improve collaborations, networks and local pathways, which I think your group is obviously trying to do as well. So it's fantastic to hear about your group. There's lots of information already out there, and I've just kind of popped a couple of different things that are already out there, but I guess it's how do we make sure that people know that they're out there, and many of them are not specific enough, I don't think, to rehabilitation. They're quite general. So that's really all I've got to say. I'll pop up just a little plug in there for a public talk that's coming up with the National Centre for Healthy Ageing. If you go onto our website, you can join up with the National Centre for Healthy Ageing. We kind of run talks every now and again, and our director, Belinda Shrikant, is running one on the ageing brain and dementia coming up in a couple of weeks, Tuesday the 25th. So if you're interested in that. But yeah, that's well, I'll stop sharing, and I'd really love to get your thoughts on how we might solve this problem. And of course, asking any questions at all as well. And Kate, please step in and see if I've missed anything.
Sorry, Michelle, can I jump in and ask a question? Is that okay? It's Rachel up top. Hi, I just want to know, like, if we're referring people to a physio for rehabilitation services, what are we putting as the reason for referral?
Well, I mean, I guess it might be, it's probably asking the person or the family member a few questions. I mean, I think the role of physio is really broad. So it might be that the person wants to increase their physical activity because they want to prevent or slow cognitive decline. So we know that physical activity is really important in terms of it can increase blood flow to the brain. It can actually increase the amount of neurons in the hippocampus. It can increase connections, and there's evidence that it can slow cognitive decline. So it might be that people would like to start exercising to reduce cognitive decline. It may be that somebody wants to maintain their ability, or they can't garden anymore. So they, because they can't get down low enough, and so they might want to have that goal of being able to do that. They might want to get back into bowls or something like that. So it's really trying to look at the goal that the person has and see whether exercise is a key component of that. It might be that the person's had a number of falls, and so it might be to reduce falls risk. But it could also be to help the care partner with transfers and mobility. I mean, that's another area. And I also recently heard of I can't remember what the organisation is called, but so if someone's behaviour is due to, the agitated behaviours are due to pain in particular, or lack of movement, physiotherapists are really good, obviously, at seeing if they can provide exercises, or it might just be movement that someone needs. So I think, there are so many things that exercise is important for. Neuroplasticity is, in no way not relevant to people with dementia. We know so much about it for stroke. Doing new things, maintaining exercise, it helps maintain social connections. I think one of the slides that I had there was a dementia golf group, I think it was. Yeah.
And is there any way to find physiotherapists that work with people with dementia? Is there a physio association that sort of lists people that do that, or yeah?
Really tricky. So the Australian Physiotherapy Association has a specific gerontology group. So people will do specialist training in gerontology. It's unlikely to say specifically dementia.
Okay.
So, I mean, you can look on people's websites, but if it was me, I would try and find somebody who either was a neurological physio and knew a lot about neuroplasticity, but it's probably going to come down to, I suspect, education from the person as well. Kate, you've obviously had experience in this.
Yeah, I did. I just wanted to add to that, really, to maybe add a bit more context to your questions, Rachel. Certainly for me, when I was diagnosed with dementia, which is over 14 years ago, I was just told to give up work and go home and get my life affairs in order. By the way, start going to daycare, respite a day a month to get used to it. I was a full-time working mum with 2 teenage kids studying a double degree. How can you go from that with disabilities to no life the next day after your diagnosis? And I was seeing a neurophysiotherapist for a different condition, different health condition. And some of you will know him, James McLaughlin, and Michelle, we need to get him on the team as an advisor next year. And I said to him one day, and he's a gait and a stroke specialist, and after my uni had said to me, well, what do you have to give up for? You've just got early stage dementia, they're disabilities. We support everybody with disabilities. We can support you. So I said to James one day, I want you to treat me for dementia now, not just the other health condition. And he looked a bit quizzical, and I said, just pretend I had a stroke at the age of 49. Do whatever you would recommend for someone with a stroke. So he did, and I started going to brain injury unit, hydrotherapy sessions, and a whole range of other extra activities. And initially I did start an exercise program, but I found that I either couldn't remember what the exercises, how to do them, or I'd forget to do them. So and I was having a lot of falls, and I have visual, spatial change. I've had spatial and depth perception changes. So I was banging into doorways a lot and falling down, you know, my own steps at home right through the wall, like, you know, like a cartoon character going through the wall. And since I've had an exercise physiologist, and I go 3 times a week, plus I have hydrotherapy once a week, my falls have almost stopped. My spatial awareness has improved. My balance has improved. And really because of the success that James felt I was having, he started to incorporate rehabilitation for dementia in his Masters of Neurophysio program. And I kept trying to, like my neurologist, Dr. Cass, would say, oh, you're just not progressing as we predicted. And I say, oh, well, I think that's because I'm doing rehabilitation. And he never wanted to hear about it. And so I said to James one day, I get retested with imaging, SPECT and PET and MRI and neuropsych testing about every 18 months. And so as a way of getting James to connect with Dr. Cass, after a round of testing, I said to James, I want you to see all the latest results, and that will be a way for you to talk to Dr. Cass. And then the next time I went to see Dr. Cass, which was, I don't know, 6 months later or 12 months later, he said, oh, I heard from your neurophysio that you're doing rehab for your cognitive changes. He said, do you want me to send you to a proper, like an intensive rehabilitation program? And I said, yes, please, I'd really like that. And because I have private healthcare, I mean, and the average Australian possibly couldn't afford all this rehab. And I'm just in a lucky position financially that I can.
Yeah.
But I went to the rehab clinic, a private one under Memorial Hospital, and the rehab physician had never seen anyone with dementia. The speech pathologist had never seen anyone with dementia. The physio had never seen anyone with dementia. The person in the hydrotherapy pool had never seen. So I spent the first 4 weeks teaching people about dementia and what I wanted from them. And then I spent the next 4 weeks with them really working intensively with me. And that really changed Dr. Cass's attitude. But I mean, I think the challenge is, unless the person with dementia or their family can afford it, you just can't even access it. But the other issue is people look at you, what would you want rehab for? Well, that's about my quality of life. And I think in the early days when I was getting some in-home care services, like an old hack package through the aged care system, all they wanted to do was take over from me, put in a shower rail, put in a ramp at the front door, and do things for me. And none of those workers ever wanted to support me to do for myself. And then because I had young onset, I could switch to NDIS. And I mean, aged care workers know almost nothing. I mean, support workers know almost nothing about dementia anyway. The disability support workers know not much about dementia either. So that's not very different. But all they want to do is support me to keep achieving what I want to achieve. So it's a huge difference for people with dementia. Number one, for their symptoms to be managed as disabilities. But, we should have rehab to improve our quality of life. It's not a cure. It might slow down cognitive deterioration. We still don't quite know that for sure. But it certainly improves quality of life, and increased exercise, improved diet, all of those things. They might also reduce your risk of diabetes, heart disease, cancer. Can't be a bad thing, surely.
The other thing that we often, don't forget, but I've often seen people really withdraw from doing a lot of social activities, staying at home, which also means that their physical activity reduces. And if you think, if you're at home, we all know during COVID what that did to our mood. It also, if you stop moving as much, you're not going to sleep as well. Sleep.
Gave everyone BPSD. My God.
Yeah. Sleep, then depressive growth can affect your cognition. So actually, and then, pain is affected by not moving. And so I think just making sure that people are able to get out and socialise, so that they're maintaining their activity, even if we don't call it exercise, at least, you know, getting out does increase the amount of activity. Being a little bit mentally active and physically active during the day is going to help sleep. So there's just this kind of almost circle, yeah, that they all relate to each other to improve mood. So,
Michelle, there's groups like social support groups like Caledania, like BMCH run, like Sandra's running. You've got a captive audience there of people living with dementia. Would it be a good collaboration to, I mean, the staff in those programs are already trying to address physical, social, spiritual, cognitive, introducing some of the physiotherapy into those programs, maybe more cost effective, and you've got a captive audience, a group of people living with dementia, and more these days, those groups do have cohorts of people with younger onset dementia who may be more physically able.
I mean, I think so. I mean, I think exercise is an interesting one. You've got to find what interests the person. So sometimes, you know, it's not going to suit everyone, but, you know, I mean, I think whatever activities that, you know, you do, actually getting people up and about and moving is, you know, just so beneficial. But if you've got ideas that you think, you know, we might be able to work on this, yeah, I'm very keen.
I hadn't watched it until I just watched a snippet of the teenagers in nursing homes program, which was it's sort of a bit depressing for me, because if we hadn't locked people away in nursing homes and we had kept them engaged in their communities and with their family and friends, I probably wouldn't need friends from teenagers. But I think what that proved is a lot of those older people thought that they couldn't be active, couldn't dance, and that program just proved to them that they could, and proved to everybody, really.
Can you, I mean, I guess, can you see other ways that, you know, we might increase the type of network that you're, you know, you're creating? I mean, is it quite wide in terms of, you know, the kind of people that are involved in the network in different organisations?
So this network, Michelle? Yeah, it is quite wide, and it's not only funded agencies. There are private organisations as well as private people, carers and people living with dementia as a part of that network. And we now have a reach across Melbourne with 1 or 2 people from outside, either Victoria or Australia, or 1 from outside the country. So, yeah, I guess the reach is quite wide, and we'd be happy to disseminate any information out to the mailing list, which is obviously a lot bigger than those who can actually attend on the day.
Can I just pop in here? I don't know any of you. I'm Norma Sahar. Hi. Thank you, Sarah, for inviting me. I'll be quick because I've just got to run to a meeting. I'm a myotherapist and I'm over in Hobsons Bay municipality, and Natalie Ives was going to speak today, and we have been in the process of myself and another colleague of forming an alliance with Natalie. Both myself and Marie Lapieco are just in the last, our last semester of doing our Bachelor of Dementia Care with UTAS, and from that it's been very apparent to us that there is minimal or a very large lack of representation for people living with dementia in our municipality. So we are just in the process of doing beginning our Dementia Alliance with Natalie and raising awareness in our community with the support of a couple of the councillors from Hobsons Bay. So I thought I'd introduce myself, and I'm sure we will connect a lot more, but we certainly need some support and some help. And we're doing our first community engagement on the 6th of November at the Cherry Lake Market, which is in Altona in Millers Road. So we will be there on the 6th of November, and we're reaching out to people to come and speak to us, for the community to reach out. There's 1,700 people living with dementia have been diagnosed in our municipality, but we don't know where they are. We don't know whether they're in nursing homes. We don't know whether they are at home in isolated circumstances. So this is our first reach out group to our community, to bring people out, to have people to talk to us. And the market is also run by the Lions Club. So our next step is to engage with the Lions Club to organise with Natalie to speak on behalf of dementia. And as she has young onset dementia, her story is very powerful. Anyway, I just wanted to introduce myself and say hi.
Hi, and thank you very much for coming along.
And thank you, Kate, for being so brave. You're amazing.
Thanks, Norma. I don't see it as really that brave. I just see it as my right.
Yes, but it is brave because so many people don't get to have an opportunity to have a voice, and you're creating an incredible presence and a voice for so many. So thank you.
Thank you.
I'm going to depart now because I've got a meeting, but I just wanted to pop in, and I'm
No worries.
see you
Give
again.
my love to Natalie when you see her.
I will.
Hope she's okay.
Thanks, Norma.
Thanks, Norma.
Thanks very much. Bye-bye now.
Bye-bye. Did anyone else have any other questions for Michele before we finish up this afternoon?
I had one question, Michele, from early on in your presentation, and I wish I could remember. It was when you were talking about assessing for maybe gait and cognition. And I was wondering whether the people that you assessed were already physically active or whether their physical activity had already declined, whether that factor was taken into account in that early work you did?
So in the very early work, it was a whole range of different people. And yeah, we did take that into account. With that Esprit study, which it actually started off with people who were really quite well. And so we were able to kind of really know that, we were following them up for quite a number of years, and we actually excluded anyone who developed dementia in particularly that first year, so that, we tried to go, okay, well, it's not that they've got dementia and their physical activity has declined before that. We wanted to get, a long way before they actually got that diagnosis. And diagnosis, we think, was picked up pretty rigorously. We think that because we did it it was done through regular kind of cognitive testing each year. We got medical notes. We got lots of different information. So we think that, it wasn't people getting diagnosed late. We're pretty confident that we were getting people each year if they had developed dementia. But I do agree. I mean, I think there is that kind of but that circle that, you start to decline in cognition. So you go out and do less physical activity, and that decline in cognition happens because of that as well. So yeah, bit of a circle.
Yeah, it is interesting, isn't it? The whole activity thing. I have put my cholesterol and blood pressure back into really healthy range with a really focused health regime. And my physician this morning said, he said, I'm not sure if you're dreaming or delusional, but that's not the reality. That's not the reason it's come down. And I really don't believe him. I'm sure that my extra exercise and my improved diet and lifestyle has contributed significantly to it. But gee, it's hard to get people to look beyond there being a drug for everything. And I mean, that's been the challenge, of course, with dementia, and why there's so much therapeutic nihilism, because there is no drug really. So people think there is nothing you can do.
But I mean, you just think like, I mean, if someone has already started to withdraw, stay at home, become less physically active, there is actually so much, but it does take often. Some people will be able to work it out themselves, but other people obviously need that support of a multidisciplinary team.
Mm.
Yeah.
Thanks again for stepping in.
Thanks. I hope it was okay.
Yes, thank you very
Fantastic.
much.
Yeah.
Great. Thank you.
Please reach out if you've got any great ideas for us.
We will. Thank you,
Lovely.
everyone, for attending this. The recording will be available in the next couple of days when I get a chance to put it up.
Thanks, Sarah. Thanks, everyone. Nice to see you.
Thank you. Thanks,
Bye.
everyone.
Okay. Thank you. See you next month. Bye-bye.
Bye.
Bye.